Hey, good afternoon, everyone. Hope everybody had a good week. Thank you everyone for turning in your homework. So what I'll do is I'll give you where you are, your grade status after this lecture. I'm only going to give one lecture today. So kind of an easy week this week, one lecture today, and then tomorrow, one quiz on acute leukemias. And then after this lecture, I'll do a quick review on acute leukemias. And then next week, you won't be getting another exam. It seemed like you were getting exams every other week. But next week, you won't be getting an exam, but I'm going to start putting together a review for exam number 4. And because it's the leukemias are a little bit more complicated, a little bit more difficult than identifying like a teardrop cell or a target cell. It's a little bit more complicated as you're finding out. Now we're actually looking at real leukemias. These are diseases, okay? And like today, we're going to be talking about lymphomas and non-Hodgkin's lymphomas and things like that. Okay, so at this point, do any of you have any questions? So next week, it's going to be acute leukemias. I like the acute leukemia section. You know, the M0 to M7s and things like that. Those are, I think they're interesting. I don't think that they're cool, but I think they're really interesting to know. Any questions? Okay, other than that, let's go ahead and get started on lymphomas. Okay, lymphomas, they're a group of diseases that come from the lymphoid tissue. And the lymphoid tissue are, of course, the lymphocytes, the histiocytes. You know what histiocytes are? They're former macrophages, and reticulum cells. And the reticulum cells are actually cells in the lymphoid tissue that are part of the connective tissue network of the lymphatic system, okay? And there is a specific lymphatic system where lymphoid fluids and it's a whole network in the lymphoid system, okay? And I'll show it to you later. Two major categories of lymphomas. You got the Hodgkin's disease or Hodgkin's lymphoma, and the other one is non-Hodgkin's lymphoma or lymphocytic lymphoma, okay? Subcategories of lymphoma, they can either benign or malignant, lymphoid proliferation, benign or malignant, or you can get Hodgkin's versus non-Hodgkin's disease. And I'll show you how the actual Hodgkin's disease is identified. There's a particular cell that pathologists look for. Unfortunately, you won't be able to identify it, but there is a specific cell that is identified its characteristics of Hodgkin's lymphoma. So there's certain things like, for example, if you have CML, the one identifying characteristic to identify CML, as you recall, is the Philadelphia chromosome, things like that, okay? So Hodgkin's lymphoma does have a characteristic cell. So benign, malignant, and Hodgkin's versus non-Hodgkin's. So, and then a little definition here, tumor, just for a clarification on tumor. Lymphomas will present as a solid tumor of lymphoid cells. It's like it presents as like a nodule or a bump. Okay, so by definition, a tumor is known as a neoplasm, and it's basically an abnormal mass of tissue which may be solid or filled with fluid. Okay, and when the doctor tells you that you have a tumor, at first, you know, you're going to think something bad, but it does not necessarily mean that it's bad at first, especially if it's early on. So tumors can be benign, it can be pre-malignant, and then ultimately it can be malignant. But by definition, the tumor itself is not necessarily cancer, okay? It can turn into a cancer. So just to make sure you know what a tumor is. And tumors in lymphomas, they often originate like balls in the lymph nodes, like a swelling. It's like a hard mass. And you'll see later on in some of the pictures that I'll be showing you. And it presents as an enlargement of the node or a tumor. Some forms of lymphoma are categorized as indolent. Indolent's a term that means it's compatible with long life. It's not really um, a significant stage in the cancer. It's compatible with long life. You can tolerate it and you can live with it. So indolent, it just sits there, okay, and until it decides that it's going to do something and cause harm to yourself. And you can live with it without treatment. And one example of this lymphoma is a small lymphocytic lymphoma, lymphoma. That's indolent, okay? So it's kind of benign, you can live with it. And then other forms of lymphoma are actually aggressive. Now, it's the aggressive ones that are of significant concern because that causes rapid deterioration and death if you don't treat it. So a good example of that is Burkitt's lymphoma. That's actually, I've heard of Burkitt's lymphoma a lot, but fortunately, the aggressive lymphomas like the Burkitt's lymphoma, even though it's aggressive, it causes the rapid deterioration and death. If you catch it, then it responds well to treatment. The patient usually responds well to treatment and they can become cured of it. So if they can catch it soon enough, then it's treatable and it's curable. So aggressive does not necessarily mean you've got, you're doomed for dying. Okay, so aggressive does not necessarily mean it's bad, but you got to treat it. You got to treat it right away. Lymphoma prognosis depends on the classification by a pathologist after examination of a biopsy or tissue sample. Okay, that's the important thing. You got to have a biopsy or tissue sample because just by appearance alone, you can't diagnose that, well, you have a lymphoma. If you have a lump on your throat or you have a lump on your neck or a lump in your armpit, you can't say, oh my God, I got a lymphoma. You can't just say by physical observation that it looks like you have a lymphoma there. They have to actually take a biopsy sample, a fine needle aspiration, or a tissue sample. Okay, definition, sarcoma. I think I mentioned sarcoma in the last lecture. It's a cancer that arises from transformed cells of mesenchymal origin. And usually mesenchymal origin is, that's a term that I first picked up when I took embryology. It's the origin of, in the developmental stages of like the embryo. So like if you recall in one of the earlier lectures where cells undergo differentiation, okay, so where bone starts to be defined, cartilage becomes defined, fat, muscle, vascular, your eyes, the number of fingers. Okay, those are, you got cells and organs of mesenchymal origin. Last lecture, I actually defined sarcoma as originating muscle and bone. So so these are cancers. Sarcoma is a cancer that would come from, excuse me, muscle, cartilage, fat, muscle, vascular, or hematopoietic tissue. Okay, that's a sarcoma. It's where it originates. Carcinoma, on the other hand, is a malignant tumor that originates from epithelial cells. Okay, it originates from epithelial cells, and that's carcinoma. So this one is a tumor stage of Mycosis Fungoides. So if you ignore this large nodule here and look around it, you see the reddening, the reddening rash. If you just ignore this and see the reddening rash, that was what the patient was showing before the nodules showed up. So it looks, Mycosis fungoides is a rash. It appears on the skin, and it may be itchy. It may be mistaken for psoriasis or eczema. But what happens is when you treat it for psoriasis or eczema and it doesn't go away, then it becomes of concern. Okay, and then later on, as this disease progresses, the Mycosis fungoides, I'll talk about the term later, then this will form. Now it starts See, the rash only affects the surface of the skin. And then once it starts infiltrating underneath the skin, then it forms these nodules, okay? So this is a lymphoma and mycosis fungoid, of mycosis fungoides. It's the tumor stage. So now she's developed a tumor. So had she treated the rash earlier, she probably would have gone to a dermatologist. The dermatologist probably treated for eczema or psoriasis and it didn't go away, or maybe it was poison oak or poison ivy and that didn't go away. So because it didn't go away, that it becomes concerning. So that's why it's important to do a tissue biopsy to find out exactly what the heck is going on. So unfortunately for this lady, she developed the tumor stage of this region, of this lesion, okay? That's mycosis fungoides. So the lymph nodes, you have 3 areas of lymph nodes, one in the neck, one in the armpit, and that's the axillary, and then in the groin. And then keep in mind here this diaphragm. The diaphragm is actually kind of like the midline, and it helps define the stage of lymphoma that the patient is undergoing. It determines what stage the lymphoma is in, okay? Okay, so Hodgkin's lymphoma. Now, Hodgkin's lymphoma is characterized by the orderly spread of disease from one lymph node group to another lymph node group. So going from the neck or to the armpit or the groin, depending on if you have it only in here or if you have it both here or if you have it in all 3 areas. But in Hodgkin's lymphoma, it's the spread of the disease from one lymph node group to another. And then you develop symptoms accordingly. The disease, this Hodgkin's lymphoma, the identifying cell that I mentioned earlier, is called the Rhine-Sternberg cell, the RS cell. And it's seen on microscopic examination, but unfortunately, you guys won't be able to see it or identify it because this is what pathologists will be looking for if he's suspecting Hodgkin's lymphoma with a tissue biopsy. And what the Rhine-Sternberg cell, it's this cell right here. If you can see it really closely, it's like, I mean, to me, this looks like a lion's face, you know, 2 eyes and a mouth. But these 3 cells together within this one circular cell is the Rhine-Sternberg cell. I was looking at it closer, and this probably look here where you got this one cell having 2 nuclei like that. That's possibly another Rhine-Sternberg cell, but this is the Rhine-Sternberg cell, and that's diagnostic of the Hodgkin's lymphoma. The rest of these cells here, as you can probably identify, are lymphocytes, okay? But this is what's seen in bone marrow, and this is what pathologists are looking for. He sees this, and he has a pretty good suspicion that this is Hodgkin's lymphoma. So that's the Rhine-Sternberg cell. Rhine-Sternberg cell, that's Hodgkin's lymphoma. Here it is again, the Rhine-Sternberg cell of Hodgkin's lymphoma. Multinucleate, has a little clearing here, looks like eyes. When we do parasitology next semester, this to me looks like if Giardia lamblia, you probably don't know that parasite, but to me, they look like eyes like this, okay? That's the Rhine-Sternberg cell of Hodgkin's lymphoma. And here's another one, Rhine-Sternberg cell seen in the bone marrow, as compared to lymphocyte. Okay? So this lymphoma was one of the first cancers that were treated using radiation therapy. So it was the first one that was used to treat radiation therapy, and it was also the first cancer that they used to treat a combination therapy with radiation plus chemotherapy. And another characteristic of Hodgkin's lymphoma, okay, another characteristic that is of Hodgkin's lymphoma that you need to know is that the disease occurs in 2 peaks. Okay, so when it's first identified, the first peak in young adulthood, it's at the age between 15 and 35 years old. Okay, so you'll get your diagnosis between the ages of 15 and 35. Okay, so you'll be labeled as having Hodgkin's lymphoma. They'll treat it, and eventually it'll go away. Okay, it'll go away when it's first treated at the young age. But unfortunately, later on, and this is characteristic of this type of lymphoma, is that a second peak will show up. After 55 years of age, it'll show up again. So it shows up in two peaks. The first one is between the age of 15 and 35, and the second peak, it'll show up again after the age of 55. Okay, so make sure you know that it occurs twice in the patient's lifetime. Okay, 15 to 35, and then later on after 55 years of age. So those are two unique characteristics of Hodgkin's lymphoma: the Rhine-Sternberg cell and the occurrence of two peaks, 15 to 35, and then later on after 55 years old. The survival rate, I think originally it was Hodgkin's lymphoma was people thought it was a terminal disease, but people can live with it. The survival rate is generally 90% or higher when the disease is detected during the early stage, and they can treat it, making it one of the more curable forms of cancer. So Hodgkin's disease used to be a long time ago a terrible cancer, but now, because of the treatment and therapies, the survival rate is pretty good, greater than 90%. And Hodgkin's lymphoma is one of a handful of cancers that even in the later stages, it still has a pretty success rate in curing, still over 90%. So Hodgkin's lymphoma is a very curable cancer. And most patients are able to be successfully treated and thus enter remission. So I'll get into the definition of what's remission and what's stable state. They enter remission and they go on to live long lives. Okay. Classical Hodgkin's lymphoma has 4 pathologic subtypes, and the 4 types are nodular sclerosing, which is hardening of the tissues, and you should know these 4. Nodular sclerosing, mixed cellularity, lymphocyte rich, and lymphocyte depleted. And these are the findings of the biopsy. Okay, it's based on biopsy of the nodule. Okay, and then the pathologist will be looking for the Rhine-Sternberg cell. But the characteristic of the nodule itself, the lump, so to speak, is nodular sclerosing, which is hardening of the tissue, and they'll see mixed cellularity versus pure. Like, for example, mixed cellularity, you probably see different populations of cells. Lymphocyte rich, on the other hand, is mostly lymphocytes, okay, as opposed to mixed cellularity. And then lymphocyte depleted, where you don't see any lymphocytes at all. So those are the 4 pathologic subtypes of classical lymphoma. Make sure you know these 4: nodular sclerosing, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Okay. To determine the stage of the disease, the patient will undergo a series of tests and procedures to determine the areas of the body affected. So staging will include all of these, a battery of tests. So sitting down with the patient, they'll take a documentation of their histology, they'll do a physical examination, they'll do blood tests, of course, they'll be doing chest x-rays, CT scans, PET scans, MRI of the chest and abdomen and the pelvis. MRI is magnetic resonance imaging, CT is computerized tomography, and PET scan is positron emission tomography. Those are the 2 different types. You got typical CT, which is used commonly these days, and PET scan is another type of CT scan, but it uses positron emission tomography. MRI is another imaging you got to make sure that you don't have a metal on your body when you do an MRI test, and then you do a bone marrow biopsy. Okay, so the Ann Arbor staging classification. Make sure you know all 4 stages. So stage 1 is involvement of a single lymph node. Okay, you only have one lymph node involved. Okay. in the lymph node region or single extra lymphatic sites. Remember, I told you the neck, the armpit, and the groin. If it only shows up in one lymph node region, then that's stage 2. I mean, stage 1, excuse me. Stage 2 is involvement of 2 or more lymph nodes, but they're on the same side of the diaphragm. So remember, I had the diaphragm. Let's go back to that. So if it's on the same side of the diaphragm, here's the diaphragm here. So if it's in the armpit and lymph nodes only, then that's stage 2. If it's in one area here or one area here or here, then that's stage 1. But if you have 2 on one side, that's stage 2. Okay. Stage 3 is involvement of the lymph node region on both sides of the diaphragm. So you have one side includes the neck and the armpit, and the other side includes the groin. So if you have the groin plus one other region, because the other 2 regions are above the diaphragm, then that's now stage 3 because it's on both sides of the diaphragm. Both sides of the diaphragm, the groin plus another region, armpit or the neck region. That's stage 3. And then for stage 4 is disseminated involvement of one or more extra lymphatic organs. So now you have involvement outside of the lymphatic organs. So you're seeing the spread of the cancer outside of those lymph nodes. Okay. Remember, extra means outside. Extra lymphatic organs. So outside the lymphatic organs. So the main regions are the neck, armpit, and the groin. So if you see involvement outside of those regions, then now it's stage 4. It has spread outside of the lymphatic system. Signs and symptoms of Hodgkin's lymphoma. The patient experiences night sweats, unexplained weight loss, and the most common symptom of Hodgkin's lymphoma is painless enlargement of one or more lymph node. So make sure you know that that's the most common symptom. And that's why I have it in red there, okay? Painless enlargement. You'll think that, okay, I got the swelling in my neck, or I have this lump in my armpit. It doesn't hurt. You know, you'll be asked, what does it hurt? And he goes, well, it doesn't hurt. It's just annoying, okay? If it's annoying, it's probably painless. And so it's still concerning. You need to have it followed up. So Hodgkin's lymphoma, like I said, can be a painless enlargement of one or more lymph node. The nodes of the neck are the most frequently involved, usually 80 to 90% of the time on average, that you'll get involvement of the neck and shoulders, or the cervical and supraclavicle. To a lesser degree, enlargement of the spine in Hodgkin's lymphoma, and that's 30% of the time. So most of the time in Hodgkin's, it's involvement of the neck and shoulders, 80 to 90%. 30% is an enlargement of the spleen, and to a lesser degree, you're going to have enlargement of the liver, and that's 5%. Okay, so that's the areas where Hodgkin's lymphoma will affect. First, the head and neck, the neck and shoulders. Next is the spleen, and next is the liver. Risk factors. Males will get it more than females, and the age groups, you'll get it, like I said, at 2 times during your lifetime. The first peak is between 15 to 35 or 15 to 40, and then later on after 55 years of age. Family history is important too. That's a risk factor. Another risk factor, and we talked about it in other lectures, in the lymphocyte lecture, is history of infectious mononucleosis, or infection with the Epstein-Barr virus. Remember, infectious mono is caused by this virus, Epstein-Barr virus, which is the causative agent of infectious mono. Okay, so that is diagnostic. The pathologist will probably run serology on one of the Steenberger cells, and that cell will be found to be infected with Epstein-Barr virus. Another risk factor for Hodgkin's lymphoma is a weakened immune system. So it's common in patients who've been infected with HIV/AIDS because HIV and AIDS is those patients are immunosuppressed. They have a weak immune system, so they're susceptible for infection. So that's another risk factor for Hodgkin's lymphoma. And then prolonged use of human growth hormone, and that's something that's up and coming, where people are using human growth hormone. And so that's becoming a risk factor for use of human growth hormone is becoming a risk factor for Hodgkin's lymphoma. The Reed-Sternberg cell, that's the identifying cell. It's identified as the large binucleate cell with prominent nucleoli, as you saw it. To me, it looks like cells with eyes, nucleoli. Immunophenotype is CD45 negative, CD30 positive, 15 plus minus. So in approximately half the cases, the Reed-Sternberg cell, as I mentioned earlier, these cells are actually infected with the Epstein-Barr virus. So make sure you know that if you have a positive infection for the Epstein-Barr virus, that another possibility other than infectious mononucleosis is that you probably could be looking further into having Hodgkin's lymphoma, because the Epstein-Barr virus will have a tendency to infect the Reed-Sternberg cell, which is the identifying cell for Hodgkin's lymphoma. Okay, so just because you have a viral infection, okay, no big deal, viral infection. You'll probably see it on the CBC, and that's, as you recall, if you have atypical lymphocytes. If you have atypical lymphocytes, that's an indicator that the patient will have infectious mononucleosis. So increased atypical lymphs, possible infectious mononucleosis. You'll do serology. Oh, this patient's positive for Epstein-Barr virus. Okay, so even though it's positive for Epstein-Barr virus, if you want to look further, then the patient, and if there's like patient has nodules or lumps in the areas of the neck, armpit, and groin, then you probably might want to rule out Hodgkin's disease or Hodgkin's lymphoma. So those all tie in. Make sure and what ties everything in is the Epstein-Barr virus, infectious mononucleosis, atypical lymphocytes, and Hodgkin's lymphoma. Okay, so it all ties in. Okay, so we're now past Hodgkin's lymphoma, and I'm going to talk about non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. And then I mentioned earlier Mycosis Fungoides. Make sure you know that Mycosis Fungoides is the most common form of cutaneous T-cell lymphoma, or CTCL. CTCL, cutaneous T-cell lymphoma. Okay, make sure you know that term. But Mycosis Fungoides is the most common form of CTCL. And cutaneous, the term cutaneous means that if it affects the skin. So Mycosis Fungoides, it's a non-Hodgkin's lymphoma, generally affects the skin, but may progress internally over time. Remember that one patient who had the Mycosis Fungoides infection, as you saw around that lump, it was reddish, and possible psoriasis, possible eczema, or possible some kind of rash or whatever, and it was treated and didn't get well. If it doesn't get better, or doesn't get properly treated, then you're going to have progression internally to whatever's underneath it. So it starts off as a skin affecting the skin, a lymphoma affecting skin. That's why it's cutaneous T-cell lymphoma. The name is actually a misnomer, okay, because it's misleading, because it means literally mushroom-like fungal disease. Mycosis fungoides, it's like a mushroom-like fungal disease. This is not a fungal disease at all, okay? It's not a fungal infection, and it's not of any kind of fungal origin. It's only named that way because of the appearance, okay? It's only named because of the appearance. It's a mushroom-like fungal disease, but it has nothing to do with fungal disease. So that's why it's misleading. So this disease, Mycosis Fungoides, was first described by a guy named a dermatologist named Jean-Louis Alibert, okay, in 1806, a long time ago. So he first identified it, but when he identified it, he did not call it a fungal disease. And that's what the term is fungal in appearance, but it's not a fungal disease. It's not a fungal infection. So he described the skin tumors of a severe case as having mushroom-like appearance. The name was given only because of its appearance. It looks like a mushroom-like appearance, but make sure you know it's not a fungal infection. So here's some more pictures. Rashes. That's erythema all over the body. Here's another one, but it's pretty severe. Let's see. And here, this guy infected his eye. So this is Mycosis Fungoides. The cause of this type of lymphoma is unknown, okay, but it's not believed to be hereditary or genetic in the majority of the cases, and it's also not contagious. It's just a lymphoma. It's the person just gets it. It's not, like I said, it's not hereditary or genetic. It's rare for the disease to appear in younger adults before the age of 20, and it appears more commonly in males than females, especially males over the age of 50 years old. Okay, the average age at onset of the Mycosis Fungoides is between 45 and 55 years of age, and the first sign of it is like when you see the rash. Okay, the rash is called either a patch or a plaque, and a patch is level. It's flush to the level of the skin, and when it rises a little, then it's called a plaque. A patch is, like I said, is flush to the level of the skin, and a plaque is actually a rising or a wrinkling of that area. So it affects patients, but not over the age of 60. Okay, and so it's over 60 for patients who present with tumors, erythroderma. Erythroderma is reddening of the skin, or a leukemic form of the Mycosis Fungoides, and that's the Accessory syndrome. So once it becomes cancerous, then it's going to progress into the leukemic form. When Mycosis Fungoides progresses into the cancer, the leukemic form, and make sure you know this, is Accessory syndrome. Accessory syndrome, and you actually see what's called accessory cells. And I'll talk about that a little bit more coming up. So you have the Mycosis Fungoides, it's the rash, and remember that lady with the throat and a nodule, that she probably had progressed to the more leukemic form, and there probably would be accessory cells present in that Mycosis Fungoides. Okay, so accessory cells or accessory syndrome is the leukemic form of Mycosis Fungoides. So Mycosis Fungoides has an unusual expression of CD4 T cells, but it's the most common type of CTCL. Remember the term cutaneous T-cell lymphoma, cutaneous T-cell lymphoma. Mycosis Fungoides is the most common type of cutaneous T-cell lymphoma, as opposed to other types of CTCL that have nothing to do with Mycosis Fungoides. And those other disorders are treated differently. The most common is the Mycosis Fungoides. Symptoms, diagnosis, and stages. Typically, the symptoms include rash-like patches. So that's what you're going to see. Tumors and lesions can be itchy. Itching pruritus is common in 20% of the patients. Diagnosing Mycosis Fungoides can be difficult because it can resemble, like I mentioned, eczema or even psoriasis. Okay, and the diagnosis is made through a combination of the clinical picture and examination, and is confirmed by biopsy. Remember, you have to get that tissue sample to confirm what's going on with your skin. Okay, clinical picture, examination, and confirmed by biopsy. And here's some more lovely pictures of Mycosis Fungoides. Here, here, and here, and here. Okay, enough pictures. Okay, to stage the disease, okay, various tests may be ordered to assess the blood and internal organs, involvement of the internal organs. Remember, it starts off cutaneous on the skin, but you want to catch it before it starts becoming invasive to the internal organs. Okay, most patients present with the disease apparently confined to the skin, and that's good if it's confined to the skin, as a patch. And a patch, like I said, is flush with the skin. It's a flat spot on the skin, as opposed to a plaque. And a plaque is slightly raised or a wrinkled spot. Okay, so make sure you know these definitions. Know the difference between a patch and a plaque. Treatment and cures. Okay, so more definition. If the treatment is successful, the disease can go into a non-progressing state or remission. So it's not progressing, it's now in remission. So when you're in remission, the disease is not there, it's gone. The disease is gone, and it can last indefinitely. So that's remission, the disease is not there. As opposed to treatment can cause the disease not to progress. This is called stable disease. So when the term is called stable, the disease is still present. It may last indefinitely, but it's a more serious condition because the disease is not gone. It's just not progressing. Okay, it's just not progressing, but it's not progressing, it's stable. If it's gone, then you're in remission. Okay, so know the difference between remission and stable. The disease, if it's stable, then there's a possibility, because it's still present, that it may progress and involve lymph nodes, blood and internal organs, or transform into a higher grade lymphoma. Okay, like remember, it could, Mycosis fungoides can progress into the Accessory syndrome or Accessory disease. Okay, treatment. The types of treatments that the patient can get is just simple sunlight, okay, because it's cutaneous, or ultraviolet light, or topical and systemic chemotherapies, local supervision radiotherapy, total skin electronic beam radiation, and biological therapies that include interferon. Remember, I talked about interferon in the previous lecture. And then retinoids having to do with vitamin A. A retinoid is a chemical compound related to vitamin A. And a rexinoid is a chemical compound that binds to vitamin A. So these are therapies for the mycosis fungoides or the non-Hodgkin's lymphoma: retinoid and rexinoid and interferon. The goal in treatment, as I mentioned earlier during the leukemia lectures, is that when you treat a lymphoma, you want to consider quality of life, because sometimes the actual therapy, if you give medication, it makes the patient sick. And if it makes the patient sick, especially if they're elderly, it can really diminish their quality of life. They're most of the time sick, they're anemic, or they're throwing up, or whatever, they lose their hair. Definitely not really good quality of life, because if you can live and tolerate the disease with minimal treatment, then that may be a good thing. So quality of life is a major objective in addition to cure. So the goal, when you're considering treatment, is maximizing periods of remission. Remember, remission, or the stable state, where the disease is not doing anything, it's not progressing, or it's actually absent, while minimizing treatment and toxicities, because the treatments can be toxic. And those are the two central concerns in clinical care. You want to balance it out and make those significant considerations. You want to make sure that you have good quality of life, the cancer's not spreading, but you also need to weigh whether or not, if it's spreading, then you need to consider whether or not you want to go through the treatment. Okay. And I talked about the Accessory disease and the Accessory syndrome. that's the leukemic phase of Mycosis Fungoides. It's the leukemic phase of Mycosis Fungoides. So when the cells of the T cell, cutaneous T cell lymphoma are now becoming systemic, and that's why it's leukemic. The cells are now floating around in your bloodstream. So the Mycosis Fungoides has now progressed to the Sézary disease or Sézary syndrome. And this was discovered by a guy named Albert Sézary. Okay, so it's a variant of cutaneous T-cell lymphoma, and it represents the leukemic phase of Mycosis Fungoides. So Mycosis Fungoides has now progressed to the leukemic phase. It's going from cutaneous to now it's becoming systemic. Okay, so that's the progression of this lymphoma. It starts off as cutaneous, and then when it becomes systemic or the leukemic phase, then that's when you have Sézary disease or Sézary syndrome. And there's a specific cell way the cells look like. The typical patient is an older patient with generalized erythroderma, pruritus, or itching. Okay, so this again is the Mycosis Fungoides. You still get the erythroderma and the pruritus and itching. So that's the Mycosis Fungoides phase of it. The Sézary cells are circulating in the peripheral blood because now the Mycosis Fungoides has now affected the internal organ underneath the cutaneous portion of the lymphoma. Now it has become invasive, and you got Sézary cells now floating around or circulating around in your peripheral blood. The Sézary cell, because it's the malignant phase of the Mycosis Fungoides, is the malignant pleomorphic T cell. Okay, so these are T cells, but now they're malignant. This is not a good stage of the Mycosis Fungoides. So the Sézary cell is the malignant pleomorphic T cell. So it happens probably because either treatment was lacking or treatment was late or they caught it late. So these are Sézary cells. Whenever you see cells like this is one cell, but if you see two nuclei like that, that's a cancer cell. If you see any cell that has two nuclei, it's not necessarily a Sézary cell, it's a cancer cell. Or and this is a lymphocyte. I'm sure you would not identify this as a monocyte because not the dull gray cytoplasm. This is lymphocytic. But look at the shape of the nucleus. Typical lymphocytes, as you recall, are round. It's more solid, but you're not going to get this flower pattern like this. So this is identified as a Sézary cell. Okay, very, very abnormal lymphocyte, different shape. This one also has two nuclei. Again, looking at the cytoplasm, it's the cytoplasm is not a monocytic cytoplasm. It's more lymphocytic because it's clear and it's blue. Same here. It's clear and blue. That's a typical lymphocyte cytoplasm, and it's dark as opposed. So lymphocyte versus monocyte. So you should be able to at least identify these two cells are lymphocytic in origin, and they're actually T cells. Okay, these are T cells. More Sézary cells. On these cells, you can at least see that they're lymphocytic because the nuclei are dark blue, but they're still not the circular form. There's still something about them that tells you that these are not right. These are not shaped correctly. So, but these are Sézary cells. Okay, they probably saw that there's erythroderma, there's a rash, and they did a biopsy, and this is what they saw in the blood sample. So these are Sézary cells, and another Sézary cell. This is lymphocytic. It's large. Look at the cytoplasm. It's not dull blue, so it's not monocytic. Almost monocytic nuclei with a little bit of folding here, but it's not a monocyte. But there's a little bit folding here. It's large, and this is another T lymphocyte. Okay. The incidence of non-Hodgkin's lymphoma among men is increasing at a rate of 0.4%, and that's during the years of 1991 to 2005. And I'll probably get a little bit more recent numbers, but it's increasing. by 0.4%. And then among women, it increased by 1.2% per year during the same time period, 1990 to 2005. Deaths from non-Hodgkin's lymphoma actually decreased by 3% between 1997 and 2005. So the deaths have increased probably because of improved therapy. The incidence probably increased because of better detection. Okay, so the incidence increased because of better detection, but the deaths decreased because of better therapy treatment. And in women, it also decreased by rate of 3%, men 3.7%. Okay, so better therapy and better detection. The aggressive large follicular lymphoma is a fast-growing cancer of a cell, of a type of thyroid cell. Okay, the indolent, remember, if you see the term indolent, that means it's not very, as opposed to aggressive. Indolent means it's not aggressive. The indolent cutaneous T-cell lymphoma is a slower growing cancer affecting the skin. And the aggressive form is faster growing type of the thyroid cell. So again, indolent versus aggressive. Okay, treatment therapies. Okay, in some types of advanced non-Hodgkin's lymphoma, you can get bone marrow or stem cell transplants. That's one type of therapy. Another one is immunotherapy or radioimmunotherapy using Zevalin. Okay, treatment with Zevalin. And then monoclonal antibody therapy is another way to treat non-Hodgkin's lymphoma. Now, if you click on these in your lecture, on your PowerPoint, if you click on them, these are actually hyperlinks. So you can control click and then read more on these types of treatments. Okay, so what causes non-Hodgkin's lymphoma? It's still unknown. And the current thinking is that there's probably a genetic factor that the cancer may not start without a trigger. So there's a trigger mechanism, and it may be environmental. So not a clear understanding on how non-Hodgkin's lymphoma is obtained. And that's it for this lecture. Hodgkin's and non-Hodgkin's lymphoma, CTCL, cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma, talked about the accessory cell, mycosis fungoides. Remember, it starts off as cutaneous, then it will progress to the internal organs, and it progresses into the Sézary syndrome, Sézary disease, and then you have the accessory cell. So this is the Hodgkin's lymphoma and non-Hodgkin's lymphoma. Are there any questions? Wow, it's not even an hour. Any questions?
I have a question for you.
Okay. Yes, Rudy.
I believe that you mentioned to us that there's two times that a non-Hodgkin's and Hodgkin's lymphoma shows up. Is that correct, or is it?
No, only Hodgkin's.
Okay, Hodgkin's only. Okay.
Right. That's the one. So Hodgkin's lymphoma is, there's two unique characteristics of Hodgkin's, and that's the Reed-Sternberger cell, right? And the other one is it's identified between the ages of 15 and 35. That's the first peak. And then it'll appear to go away and you think, wow, I licked this thing. And then unfortunately, after 55, it'll show up again. So it shows up in two peaks. And that's the Hodgkin's lymphoma. The non-Hodgkin's lymphoma is the cutaneous T-cell lymphoma. And that's the most common one, is the Mycosis Fungoides. Okay. And the progression of that disease, the cutaneous T-cell, is the Sézary syndrome. Remember, with the Sézary cell, it starts off as a patch plaque, right? Cutaneous. And then if you don't treat it, then it'll progress to a lymphoma that'll affect the internal organs. And that's where you get and that's called the leukemic phase. The leukemic phase of Mycosis fungoides, and that's where you get the Sézary cells circulating throughout the peripheral blood. Okay.
Thank you.
You're welcome. Any other questions? Okay, if not, I just wanted to verify schedule-wise. So there's no school the week of November 22nd. Is that correct? Just wanted to make sure. No class the week
We
of
should have the whole week off, I believe.
whole week off. So November 22nd, no no class. Perfect. Just and then the last day of class, the week of finals. Is that like December? Let me see. Take a look at my schedule here.
I think that's the 14th of December.
14th. Because you're not going to have an exam next week, so that's why it's kind of easy right now. One lecture a day, today, and then last week, and then today, and then no exam next week. So, all right. So today is the 27th, and you have a quiz tomorrow, and I'll do a review for that. And then next week, you only have one quiz on the lymphoma, non-Hodgkin's lymphoma, and no exam. So no exam today, no exam next week. And then I'll do a preparation next week for exam 4, which will cover lectures 14 to 18. And then because you only get one lecture next week, then you'll have one quiz. And then I have you. So next week, on November 3rd will be your last hematology lecture. That will be your last hematology lecture. And then following that will be coagulation. And then it's going to go by pretty quick. So November 10 will be the start of coagulation, introduction and coagulation terms. The 17th, a couple more lectures. The 17th and 18th, you'll have quiz. On the November 11th will be your last hematology exam, 14 to 18. And then you'll have exam 5. So I broke it up into 2 exams for coagulation, where I'll cover lectures 19 to 22. And then your final exam on, see, I have you on December 8th as your finals week. Is that right? Would that be correct? If not, then you're going to leave early. Is that okay?
The 14th is a Tuesday, so I think that's why finals for you would be on that week of the 8th.
The week of the 8th. So this exam actually will be given in the laboratory, because I won't be, usually I give a lecture and then I give an exam. So December 8th, there's not going to be anything. So on December 9th, I think is your laboratory date. And that's where Xavier's going to give you this exam right here, exam 6. When is your chemistry exam? Do you guys know? No?
On the,
I'm sorry, say that one more time.
or I guess on the week of the 14th. Yeah, so it would be on the 14th, the Tuesday. And
Okay,
then
that'll be fine, because you guys will be done with hematology then. You'll be done with hematology, and then that way you can focus on chemistry. So all right, that's good. So on this day, December 9, you'll be finishing up your differentials. If you need, then maybe you can do it on the 16th. I don't know. That'll all depend on Xavier. That's his class. He's teaching the class, and it will be up to him. So I'm estimating. I gave this schedule as a proposal for him to use, depending on how you guys want to do your differentials. The differential exercise is you're going to be given smears, and you're going to be doing actual differential counts and on actual patients. And then he has the the true numbers, and he'll be looking at how close you'll be comparing. And if I was teaching the laboratory, then I would have like a 10% tolerance of difference. Okay, so it's kind of weird this semester. I'm not teaching the laboratory, but Xavier is helping out by teaching the laboratory. So hopefully, when I teach this class again next semester, I'll be able to do, you know, if I had the laboratory, I'll be able to do some lecture stuff in the laboratory, and vice versa. Like, especially without a board. I mean, this Zoom thing is kind of difficult, but without a classroom setting, I think it's harder to teach. So looks like you'll be done with hematology on the 9th, and you'll be getting your exam 6 on chapters, lectures 23 to 25. And then on the 2nd, you'll be getting an exam 5 on lectures 19 to 22. And then not next week, but the week after, on November 11th, you'll be getting an exam on lectures 14 to 18. One quiz tomorrow, one quiz next Thursday, one quiz on November 11th, but then one quiz, but then you'll be getting an exam. And then on next week, November 3rd, I'll do a review for exam 4. All right. Any questions? So it looks like you'll be done with hematology a week early, and but that'll give you enough time to prepare for your chemistry and whatever exams you have in your other classes, like serology or intro to MLT. Is that pretty much a schedule for your other classes, or is everybody going to be on the week of the 14th?
For immunology, it's on the same week as yours, so it would be on the 8th of December.
Oh, okay.
And then hematology is on the 9th, and then the following day we have the exam for intro. Then the following week, on the week of the 14th, that's when we have chem and urinalysis.
Okay. This semester's been different. Dina had really shortened. This class used to be 2 days of lecture a week, and then she compressed it to 1 day of lecture a week and 1 day of laboratory. And so seeing how that Dina gave us schedules like that, I know it was, I had to do a lot of rearranging of my lectures, where, as you can see, that a lot of cases I did 2 lectures a day. And I know in chemistry that Myrna has a lot of lectures to give too. Did she have to end up doubling up on her lectures as well?
Sometimes she is in part of lab because the lectures are so heavy.
I know. And her lectures are like over 100 slides long too. I know they're pretty long. So yeah, see, so she used the laboratory to supplement her lecture. So I use the laboratory to supplement time to do your quizzes and exams. So then all I would do is focus on the lecture. Okay. Any other questions? So schedule is a little clear. You know, you'll have a week off for Thanksgiving, and then one more lecture in hematology, and then we move on to coagulation. All right. Okay, so you have a quiz coming up tomorrow. The quiz is pretty straightforward. Let me stop sharing my screen, but you can hear me. Okay, can you see my screen? No? No?
No.
Okay. All right, so this quiz tomorrow is going to be straightforward. It's on the acute leukemias. Make sure you know the M0 to M7 or M8. Make sure you know the alternate forms like the Nagli. Remember what the Nagli is, the Guglielmo. Make sure you know, okay, it wasn't really in the lecture, but acute myelocytic, acute myelogenous leukemia is also the same as acute granulocytic. Okay, so I know it was in there. That's a term that I use when I was training acute granulocytic leukemia. They're all the same thing. Myelocytic, myelogenous, and granulocytic. They're all the same thing. Okay. Know the difference between the WHO, the World Health Organization classification of acute leukemias versus the French American British, the FAB. Make sure you know the important characteristics of those two systems. Obviously, the M0 to M8 is going to be on there, and you're going to need to match them up. Okay, remember the tricks I told you, right? Promyelocytic, myelomono, and mono, right? Let me see. We talked about mast cell leukemia, and there's a threshold that if it's above a certain percentage, then it's the leukemic form, and below it, it's the aleukemic form. Remember, make sure you know what percentage that is, percent of mast cells present. So make sure you read the section on mast cells. Make sure you know that if you have a fibrotic tap, chances are you'll get a dry tap. A fibrotic bone marrow, that means there's a lot of scar tissue in the bone marrow. What is that term of the bone marrow when you get a lot of fibrous tissue? Make sure you know the difference between sarcoma and chloroma. Remember, sarcoma and chloroma? They're both a collection of certain types of cells. Let me see. Definition of leukemia. What happens when you have leukemia? What happens to the normal cells in the bone marrow? Okay, when you have leukemia, so there's a competition or a crowding out of the normal cells, and they're actually displaced by the leukemic cells. And how do you confirm? And I kind of touched upon that in this lecture here with the lymphoma. How do you actually confirm that you have a certain type of leukemia based on not only on clinical evaluation, but you make sure you have to do things like a biopsy, okay, and actually take a look at the cells. And then the acute leukemia, make sure you know the FAB, the different classifications of leukemia for acute lymphocytic leukemia. And that should be easy because there's 3 of them. And that's pretty much it. Okay, are there any questions for that quiz? That's your preparation. Next week, I'll come up with a review for your exam. I'll send you before next week. I'll send you a review like I did last time. And when I send you these reviews, make sure you treat them like homework. If you do treat them like homework, then you'll do pretty well. And then after this lecture, I'll send you the recorded version of this lecture, and then I'll also send you where your grade, your snapshot of your grade in this class. So pretty much people have kind of settled into the grade that they're probably going to get. There's still opportunity for certain individuals to get a better grade because they're close to the margin. So we only have a few more weeks left, and hopefully with this final push you'll be able to get over the hump. So, and again, keep in mind that just because you end up with a final percentage points, I do take into consideration the amount of participation, and those were the affective objectives. So depending on how much you participated or contributed to discussion in the lecture, then that can actually help you push, and it'll help me decide whether or not should I push you over into the next grade. And for previous students in other classes, that actually did make a difference. Okay. Other than that, let's see. Other than that, I don't have anything else. All right. So if there are no other questions, then I'll have a good week and I'll see you next Wednesday.
Have a good day.
Take care.
Thank you.
You're welcome. And then, of course, if any of you have any questions, please email me or contact me.
Okay.
All right.